My interest in the aging field started when I was younger. It's a personal experience that I had. My grandmother had Alzheimer's and my uncle was the caretaker for her, and he passed away. And so this fueled my interest in geriatrics and neurology. I focused my master's at Roswell Park Cancer Institute on aging and pharmacology, and worked at their Memory and Movement Disorder Center, and published my master's thesis on validation of memory scales and dementia, and then carried on that interest throughout medical school. And I did my residency in neurology here at Montefiore Medical Center and continued on with a double fellowship here as well. This was very limited. She was actually in a walk-up apartment, so there was a lot of restrictions, and I would have focused a lot more on the caregiver because he passed away. So most of my research is fueled based on the caregiver as a functionality of the patient as well. So we focus on that at the Center for the Aging Brain and incorporate the treatment of the caregiver in our treatment plans, because if we're not able to support our caregivers, we can't support our patients as well. So I would have really focused on his risk factors for disease. He didn't have the time to go to the doctor. I would have focused on his management of vascular risk factors for heart attack, which in itself have been shown to be risk factors for Alzheimer's disease and the progression of dementia. So it would have been the treatment of his future risk as well as the treatment for my grandmother. I can't find anything else more rewarding, and I know that I failed taking care of my grandmother as a hairdresser and providing that care for her, so that was definitely not my strength. So I am rewarded every day with a patient in front of me and the ability to teach the next generation. I don't think you could put a price on that one. They need the support to navigate through the system. Here in the Bronx at the Montefiore Health System, it's unique in the sense that we have an area where, an underserved area, so we have patients with limited health literacy, with chronic problems. As a resident, it's a wonderful opportunity to practice in an environment where you do see end-stage disease. So we need to recognize that our caregivers and our patients may not have the health literacy to navigate through the health system. So part of the reason when you come into the Center for the Aging Brain, we focus on the caregiver and the patient, if they have impairment, to help them understand through our social work visits what are their qualifications. We can help them navigate through the Medicaid system. We can help them navigate through establishing healthcare proxies, advanced care directives. And even our testing at the Montefiore Center for the Aging Brain recognizes that cultural competence. We have brief screens that are picture-based for memory, and we're actually able to capture patients that way. And that represents patients that can help patients that have less health literacy, that are illiterate. So it actually takes away that need for a level of education. It allows them to be screened at the appropriate education level. There's such a difference in the cultures, and that's part of the engagement that we need. We need to recognize that there is a difference in cultures when you deliver a diagnosis. The understanding that not all dementia is Alzheimer's disease. There's many different types of dementia. There's dementia due to Lewy body disease, it's part of the Parkinson's syndromes, there's progressive supranuclear palsy, there's vascular dementia, and not all birds are created equal, but that understanding starts with the recognition that is there a dementia diagnosis? Is there impairment in the memory? Is there impairment in functionality that's contributing to this problem? And what we often see is some of our referrals are for patients that haven't been recognized by their primary care doctor. So in a place like the Montefiore Health System, they may have diabetes, but it hasn't been recognized that they have cognitive impairment. So they may not be compliant with their diabetes medication, not because of their visual impairment, not because of their neuropathy or their inability to manipulate the syringe. It's because there's impairment there as well. So that's part of the recognition syndrome. I think that understanding that age is a risk factor, that we can't choose our family members, that we can't change our genetics is important, but there is a difference in understanding of Alzheimer's disease across the different culture, and that age is a risk factor, but it's not the only risk factor, and that at any age there are many, many elderly that are living full lives that are, and I always have a picture of someone who actually is tandem jumping with a skydiver on her 87th birthday. So there's a myriad of syndromes, and there's a spectrum of diagnoses. diagnoses, and that's part of why I enjoy working with the elderly and at the Montefiore Center for the Aging Brain, because we do get to capture that. We capture the normal, the worried well, patients with mild cognitive impairment, patients who are worried about their memory, patients with Alzheimer's disease. So we get to work with those families and to try to help them understand in a culturally sensitive manner diagnoses. It is a worldwide problem. So everybody, any age, any culture, it's a worldwide global problem causing morbidity and mortality across ages. So as the population ages, we're going to see more of that. So it's more of a global initiative. Within particular the United States, I know the figures for caregiving, you're spending $217 billion was the last 2015 Alzheimer's facts, and the amount of money that was spent in caregiving. And it's about 17 billion unpaid hours of care. So we really have a global problem that we need to address. Some people who have been designated as Alzheimer's disease, they have an acceptance that this is what has been designated to them in life, and they want to empower their patients. And what we are enriched with in this type of area is that there's a lot of multi-generational families. So the patients are cared for in the home, and it's also the recognition that this has been their job. So that we have a sandwich generation now. We have the 40-year-olds taking care of grandparents that may have memory impairment as well as their children. So they're sandwiched between caring for the needs of the young and the old, and they feel that this is what they've been charged with, that this is a diagnosis that they have to accept, and we often try to re-empower families because there is that nice entity that there is this care for in a multi-generational manner.